and I also work in France. And today we're going to be discussing the role of urinalysis in the investigation of FLUTD. So just a quick conflicts of interest slide. As I've mentioned, I work for IDEXX Laboratories UK, and I'm also an employee of Anicura France. So you'll have spent a lot of today discussing what is FLUTD and what can we do about it. So just to recap, FLUTD encompasses various disorders affecting the bladder or urethra of cats. So there's a lot of different differentials that could fall into that category. The most frequent cause is feline interstitial cystitis, but we can also have cats presenting with signs of FLUTD due to urolithiasis, bacterial urinary tract infections, potentially neoplasia, potentially anatomic malformations. It can be iatrogenic, behavioral, metabolic, or even neurologic. So there's a lot of different potential conditions that can come together to produce the same clinical signs. And it's our job as clinicians to make sure we investigate this logically and clearly so that we don't overlook potentially important information and get the wrong diagnosis. So there's a little reference at the bottom of this slide that might be of interest to you if you've got if you want more information on FLUTD. So a logical approach is really essential to move forward in any cat presenting with signs of lower urinary tract disease. So I thought what we would do today is start off kind of using a case study and use that to help us with the approach to an FLUTD case, and particularly with the use of urine analysis in FLUTD investigation. So this is Marvelous Moo Cat. She was actually my cat, so very special. Unfortunately, she's no longer with us. So, but she's here with us in spirit at least. And she was a 17-year-old female neutered domestic short hair cat who had been with me for many, many years, and then fairly acute onset hematuria. So that was a concern. And what we then saw was that she was urinating outside the tray. She was urinating small quantities. She was had urgency and was actually crying when she was urinating. So there was clearly pain involved in that. So clearly signs of feline lower urinary tract disease. So just for some background information, Moo was diagnosed with hyperthyroidism 6 months earlier, and she was currently stable on oral medication. Stable meaning that I'd measured T4 and it was within a good range, and she didn't have any particular signs of ongoing hyperthyroidism. She was also diagnosed with IRIS stage 2 kidney disease 2 years earlier, and her renal parameters were stable despite her downright refusal to eat a renal diet. So that was all going okay. But things that had changed is that there had recently been a new cat in the household who had adopted us. We called him Moriarty, and that worked out to be quite a good name because he really did turn out to be Moo Cat's arch nemesis. And although they tolerated each other for the first few months, it definitely turned into a bit of a war between them after about 3 or 4 months. So as we can see from here, with escalating tensions in the household between these two cats, despite our best efforts, and an elderly cat now producing bloody urine and urinating outside the tray, it seemed very likely to me that this was a feline interstitial cystitis provoked by the stress of the tensions between the two cats. So I must admit, I was a little bit remiss in doing too much too soon because I assumed it was that, and I was focusing more on environmental enrichment, which I'm sure you'll have heard a lot about it from other people today, in order to reduce the tensions between the two cats and make sure both cats' needs were being met. But after a few days, I realized that things were getting worse rather than better. I performed a full clinical examination, and she didn't have much muscle mass. That was probably due to her age, the hyperthyroidism and renal disease all combined. She had pain and extension of her hips. She was currently receiving a product, a monthly injection to reduce arthritic pain. That was managing the pain quite well. But on palpation of the abdomen, there was certainly discomfort on palpation of the bladder, and the bladder was small and firm. So there wasn't any signs of obstruction, but the bladder was small and firm and painful to the touch. So the first steps in this case are going to be urine analysis, and that was something that we started off with Moo Cat. So how do we obtain the urine sample first and foremost? Well, in Mukat's case, she was urinating all over the floor, so it was fairly easy for me to be able to recover a small sample for a quick dipstick. So it was very easy for me to see that there was a lot of blood in it. But that's not a clean sample. So in an ideal world, and we definitely do not live in an ideal world, but such is life, I would recommend where possible that we consider a cystocentesis sample unless it's contraindicated. The reason for that is that it allows us to have an aseptic sample so that if we do decide we need to culture the urine, that it's suitable for that. There's no contamination from the lower urinary tract. There's no contamination from the floor or the litter tray, and it's quick and obtained in clinic. But of course, other options are available. There was the voided sample, which was from the floor, so not sterile or aseptic in any way, shape, or form, with the potential of contamination from other compounds on the floor. And the other option is catheterized sample, but clearly that would have required sedation or anesthesia, so that wasn't something that we were very likely to do. So in Mukat's case, I nipped into the surgery and we did an ultrasound-guided cystocentesis. And this allowed me to see that actually there was evidence of changes within the bladder. So you can see on the right-hand side of your screen here that we've got the black contents of the bladder, that's the luminal contents, which are quite echogenic, so quite cellular. And we can see that the lining of the bladder is quite irregular and thickened. So we knew there was definitely a problem, and we were to advance with our investigations for that. So when we did the cystocentesis on Mukat, it was very obvious that we had a problem. As you can see here, the urine that she was producing was bright red. So we knew that we definitely had a problem. Obviously, red urine can mean either hematuria or hemoglobinuria. So how do we investigate this further? What are the next steps in trying to ascertain the underlying cause? Is this a feline interstitial cystitis or is it something else? So when we're thinking about doing investigations for feline lower urinary tract disease, urine really is liquid gold, and we shouldn't forget about its analysis. Most people will rush into doing bloods when an animal's sick, which is all well and good. It's part of your minimum database, but that minimum database is not complete without concurrent urine analysis. So it really is essential not to overlook this, and particularly in a patient with signs of lower urinary tract disease. Oh, that's just moved forward without me asking it to. With lower urinary tract disease, it is really important that we perform full urine analysis. So full urine analysis involves physical exam, the chemical exam, the specific gravity by refractometer, and also a sediment exam. So let's talk through those steps. So physical exam first and foremost is just simply how the urine looks. What is the color like? Does it look flocculent or cellular? Is it clear? And the urine color is generally associated with urine concentration. So obviously, if an animal is quite dehydrated, the urine is likely to be much darker, whereas if the animal is well hydrated, the urine will be typically light yellow and transparent, such as that image shown here on your screen. So when it's a dark yellow or orange color, that could be just due to the animal being dehydrated and producing concentrated urine, or potentially that could also indicate bilirubinuria, which will require further investigation. So ultimately, just the color alone can help guide you in the next steps. In Mukat's case, the urine was very, very red. So this means we've either got hematuria or hemoglobinuria. And the way we differentiate between those two is by centrifuging a small portion of that sample. In hematuria, the red cells will migrate in a conical tube to the bottom of the tube as a pellet, leaving the supernatant clear. Whereas with hemoglobinuria, we will not get any clearance of the sample after centrifugation. But of course, it's possible that you can have both things, and you might have a pellet and discolored supernatant. So centrifuging the sample can help differentiate between the two. And then lastly, the other type of urine you might see is myoglobinuria, which is quite uncommon, and it tends to look fairly brown. So this kind of dark color that you can see on your bottom, on the bottom image here. So in Mukat's case, we spun the sample down and we confirmed that it was chock-a-block full of red cells consistent with hematuria. So then we move on to the chemical examination. That's involving the urine dipstick. So ultimately, this is the next step in urine examination, and that ideally should be performed within about 30 to 60 minutes of collection of urine. So this is another reason why performing a cystocentesis sample may be preferable, because that means you can go directly from patient to lab and you can perform your urine analysis straight away. If you're relying on a client bringing in a urine sample, that could mean the sample is lying overnight or several hours before that sample has been collected. And we'll explain the importance of rapid analysis of urine as we go through the rest of this presentation. So despite what the image shows you on the top right of your screen here, we really should avoid dipping the urine dipstick into the urine. Preferably, it's better to use a pipette and just place that on each of the pads and make sure that there's not excessive amount of urine on each pad. And it is important to make sure the urine is at room temperature before performing the examination. We'll focus a little bit more on why that is later on. So what's normal for urine? Well, the pH is generally between about 6 to 7.5, but that can be affected by the animal's diet, the presence of bacteria, or the presence of concurrent disease. And remember that although the dipsticks that we have available to us have various pads, there are some that may not be relevant for small animals. So for example, the nitrite pad nitrite can be produced by bacteria, but it's not commonly produced in the UTIs that animals get. So that's primarily for human use. So nitrite pad is not reliable for veterinary medicine. In addition, the leukocyte pad is neither sensitive nor specific. It tends to detect enzymes found in white cells, and these cells must degranulate to cause a positive reaction. But in dogs, which we're not really talking about today, there's lots of false negative, and in cats, there's lots of false positives. So I would recommend that you disregard the leukocyte pad in veterinary medicine. It's not very reliable. And then, of course, most of the pads do have a specific gravity pad on them as well. I'm sorry, the computer seems to have a mind of its own. Just change that back. Specific gravity pad, it's not reliable either. You absolutely must use a refractometer in order to get a representative urine-specific gravity. So speaking of which, here is the refractometer, which is essential for urine-specific gravity. The urine-specific gravity provides us with evidence of the kidney's abilities to concentrate or dilute the urine. So, for example, if urine is very concentrated, it means the kidneys are working well. And if the urine is very dilute, it means probably the animal has some form of excessive intake of water. Although remember that there is no such thing really as normal urine-specific gravity. The urine-specific gravity can vary dramatically throughout the course of the day, depending on the animal's state of hydration. So I don't like it when we discuss normal specific gravity. That doesn't really exist. But for the purposes of moving forward here today, we're going to just mention that obviously there are the three categories of urine-specific gravity: hyposphenuria, which is when the urine-specific gravity is less than 1.007, so very dilute. We've got isosthenuria, which is effectively the same concentration as that of plasma, so the kidneys are neither diluting nor concentrating the urine, so that's between 1.008 to 1.012. And then we have hypersthenuria, which is very concentrated urine. In dogs, we consider that to be greater than 1.030, and in cats a bit higher, 1.035. So there's a zone between isosthenuria and hypersthenuria, which the interpretation of that is going to depend on other factors. So we'll not go into that in too much detail just now, because this is not focused on renal function. We're talking about urine analysis and the investigation of FLUTD. But it is important when you're looking at specific gravity to interpret that alongside the clinical presentation of the animal and also the animal's creatinine measurement. And that creatinine measurement should be taken at the same time as the urine. So really we want the urine and the creatinine to be interpreted in the same window. So collecting both samples within about an 8 to 12 hour window, and preferably before fluid therapy, if that's required. So the next step in urine examination is urine sediment analysis, and this is often overlooked because it's time consuming and you may not have the equipment or probably more commonly the time rather than the equipment to do this correctly. Urine should ideally be analysed within 30 to 60 minutes of collection. So once again, cystocentesis makes most sense because it can be analysed immediately. But if you can't, if you don't have that luxury to do a cystocentesis, then you can pop the urine sample in the fridge for up to 12 hours. But it is really important to let that sample come back to room temperature before analysing. That includes for both the dipstick and the urine sediment analysis. So try and make sure it's at room temperature before doing any form of analysis. The reason it's so important to analyze the urine quickly is because some of the cellular components within urine, which may be pathological and give us an indication as to what the underlying disease process is, can start to break down within 1 to 2 hours of sample collection at room temperature. So clearly, the longer that we leave that sample, the less chance we have of seeing representative changes in that particular urine sample. We also know that refrigeration can cause precipitation of amorphous crystals, and we also know that refrigeration can actually change the urine-specific gravity because cold urine is more dense than room temperature specific gravity. So the take-home message from this slide is that really we need to do urine analysis as soon as possible after it's obtained from the patient. And if we don't do it rapidly, then we must make sure it's refrigerated, but very importantly, returned to room temperature before analysis. So from that, it makes sense that urine analysis should really ideally be a patient-side test. Clearly sending it to the lab may be something that you have to do for a variety of different parameters. But if you have the facilities in-house, a microscope or whatever to do a sediment examination, it really is encouraged that you do that patient side, because within a very short space of time, we can get a lot of changes which can impact our analysis of the urine sample. So for example, over time, crystals can either form or dissolve, bacteria can either grow or die, cells or casts may disintegrate and be unrecognizable on the sediment examination. We can get a change in pH, usually it tends to increase, and we can get lysis of red blood cells en route to the lab and deterioration of leukocytes. So with all those changes, it's absolutely likely that things can be missed unless the analysis is done promptly. So here on the side of your screen, we can see at the top, we'll discuss these later. This is likely to be a cast, but what was this? Could this have been something important? Could this have been a cast that has subsequently broken down? We just don't know. And a delay in analysis can be the difference between something that is identifiable and just a bunch of debris. So for the sediment examination, how do we perform that? Well, it requires a little bit of equipment, and in most cases, that's going to be a combination of a centrifuge and a microscope, nothing much more than that. You may be aware that the SediVue DX exists, and it kind of takes the place of the centrifuge and the microscope. It effectively does the centrifugation for you and deposits the cells onto a slide and then takes images of those, and it then uploads those images to the database where you can review those images. So effectively, it's doing the same job as you centrifuging a sample and looking at it under a microscope. So whichever you have, it doesn't really matter. Same rules apply. Rapid analysis and take the results in context with the clinical presentation. So assuming you don't have a SediVue, I'd like to talk you through how to do a urine sediment wet prep. I'm sure many of you are familiar with this process already, but just to make sure that we're all up to speed. So what you want to do is take a standardized volume of urine, so probably about 5 mils, and you want to put that urine into a conical tip tube. So something like an Eppendorf tube would be ideal. We're then going to centrifuge that, but for urine, it's very important that we're not using the same speed of centrifugation as we are for blood, because that level of centrifugation can lead to destruction of some of the more fragile elements of the urine sediment examination that we're looking for. So we would centrifuge that sample at 400 G, which equates to about 1,000 to 2,000 RPM, for 5 minutes. So that's a short space of time at a low speed. Anything higher than that, and we run the risk of destroying some of these more fragile elements. So once we've spun the tube down, there should be a little pellet at the bottom of the conical tip tube. We want to take the supernatant away. For those of you who are not familiar with that term, the supernatant is just the excess fluid above the pellet. So we discard that, leaving a very, very small amount of that supernatant with the pellet, maybe 1 to 2 drops. And then we resuspend the pellet with a small amount of supernatant. That sounds fancy. Basically, you flick the tube, so the remaining couple of drops of urine or supernatant mix with the pellet. You can then take a drop of that mixture and place it on a glass slide and place a cover slip over the top. Some people will choose to stain their sample before this point, but I don't feel it's necessary. And we'll come back to how we can look for things like bacteria, etc., later on in the presentation. So a drop of the mixture onto a glass slide, place a cover slip, and then we want to analyze this under the microscope using low-level light with the condenser lowered. So here on the right-hand side of your screen, you can see a standard microscope, binocular microscope. For those of you who aren't sure what the condenser is, you can just see it underneath the platform here. It's the little thing that you can move up and down. That's the condenser, and we want that to be lowered. And we also want to reduce the amount of light coming through because it will be easier to see some of the clear elements that we might identify in the urine sample. So we start our examination at low magnification, so at ×10, and this will generally allow us to identify casts and crystals. So we should be able to see most of the kind of elements in the form of casts or crystals at a low magnification. We want to scan at least 10 fields to make sure we're not missing anything. And then if there's any areas of interest, we can then increase the magnification to ×40 to get a closer look at them and scan again about 10 fields. So very simple to do, but a bit time consuming. And I think that's why it's often overlooked. I tend to find nurses are much better at this process than vets are, probably because they're infinitely more patient than we are. And as I say, if you have a sediview, it kind of does the same process for you. But either way, the sediment examination is a vital part of the full urine examination. So now what we'll do is we'll move on to what we're likely to see on that sediment examination, because many people are a little bit reluctant to confirm what they're seeing. They're not confident in their own abilities as to what they're looking at. So hopefully after this, you might have a better understanding of what you're looking at and more confidence in moving forward with the diagnosis. So we're going to start off with the epithelial cells. So epithelial cells are the larger than any other urine constituent. So if you're seeing something large in the urine, something like this on the right-hand side of your screen, there's every chance that's going to be an epithelial cell. But there are various different types of epithelial cell. We can have squamous, which are the largest, transitional, or renal, which is the smallest, with transitional between the two. So they do vary in size. The smallest originate mainly from the kidneys, and the largest, which are the squamous cells, originate from the distal urogenital tract, including the urethra and the prostate. So these cells will be identified in a variety of animals, and I'll explain where you're going to find them on the next slide. So I'm not going to talk so much about the renal epithelial cells because it's quite rare that you'll come across them. But so the two that you're most likely to see are either the squamous epithelial cells or transitional epithelial cells. So squamous epithelial cells on the left-hand side of your screen, these are the cells that line the surfaces of the external genitalia and lower urinary tract. So we will have low numbers present in normal cats in free catch samples. But we will also have increased numbers if there's any inflammation present, such as urethritis, UTIs, and also just in catheterized samples because I guess there's some trauma there. So infections can increase their numbers. It can also be increased with neoplasia, but we will identify these cells in normal cats in both free catch and catheterized samples. So what do they look like? Well, they're larger than the other type of epithelial cells. They're large and quite thin. They're quite angular, as you can see here. They tend to have a small round nucleus. You can just see the little pale nucleus in the center. And as I say, they're quite common in voided or catheterized samples. So their presence doesn't necessarily mean they're abnormal, but if they're present in very large numbers, that might be something you want to look into. Compare that with the transitional epithelial cells. These originate from anywhere from the renal pelvis right the way through to the urethra. They tend to be 2 to 4 times the size of a white cell. So if you can find a white cell in the sample and compare the size, that gives you an indication of what you might be looking at. They tend to have 1 to 2 nuclei, and they tend to be somewhat pear-shaped or round and might have tail-like projections. So here on the kind of highlighted image, you can see this one with a little tail, and these ones here, which are more round with the nuclei present in the center. So wouldn't it be nice if there were big arrows pointing out what each cell was? Well, actually, if you have a SediVue, it kind of uses artificial intelligence to do that for you. But it's always good to review that with the human eye. So that's a brief overview of epithelial cells, which you're likely to see in urine samples. And I now want to move on to casts. Now, you probably have noticed, or maybe you will more so after this presentation, that actually finding casts on your report from an external laboratory is quite uncommon. And the reason for that is these are such fragile elements that unless you're looking for them in-house, then it's probably quite likely that they'll have been destroyed en route to the lab. So can't impress on you enough, even if you are sending a sample to an external laboratory for urine analysis, please do have a look in-house as well. There'll be more information you can gain from that and compare and contrast with the information you're getting from the lab. It really is very important to look at this in-house and as fresh a sample as possible. So what is a cast? Well, it's effectively mucoprotein or cell debris. They're formed in the renal tubules, so that can be the proximal, the distal, or the convoluted tubules, and we recognize them by their form. So they tend to be somewhat cylindrical with parallel sides, as you can see here, and they tend to be longer than they are wide, so a little bit like cigars in some instances, and the ends are either rounded or tapered. Small numbers of hyaline casts, for example, can be present in healthy animals, but other than that, they're generally not a normal finding. Generally, their presence in any numbers would indicate renal tubular pathology. But as I've mentioned, small number of hyaline or potentially granular casts can be normal. So look for these in-house and look to see how frequent they are. If you're finding them frequently, rather than having to really search to find them, then that would indicate that you've got a problem. The appearance of the cast depends on the length of time it's remained in the tubules before being shed into the urine. So all casts kind of start off as hyaline casts, which I'm going to show you in a second. And then depending on the length of time that they're retained before being shed will dictate what they subsequently look like. So for example, cellular casts are shed shortly after being formed, whereas waxy casts, which are one of the more rarer forms, tend to be retained longer before being shed. So let's move on and see what some of these casts look like. But as I mentioned, it's difficult to identify casts because they are very fragile. So if you are spinning your urine too violently with a high centrifugation rate, or if you're not looking at fresh urine, there's every chance these will have disintegrated before you get an opportunity to identify them. In addition, they're also shed intermittently in urine, so their presence certainly indicates there's a problem if it's more than one per low-powered field for hyaline casts, for example, but absence of casts does not mean absence of disease because they're so fragile. So they will deteriorate in stored urine, they'll deteriorate in alkaline urine or dilute urine. So they really are precious little bundles and they need to be identified as soon as possible. There's also quite a high variability in the operator's ability to identify casts because it may not be something that you're very familiar at looking at, but it is important once again to turn your light settings down. They can be easier to find if the light settings are much lower than you would typically use. So a little tip just to turn your light settings down if you're looking for casts. So hyaline casts are the primary forms of casts and from which all of the others form. They are colorless to semi-transparent. So here on the top hand side of your screen, I should have indicated if any of the images I'm showing you are gray, black and white, then that will be a SediVue image. Whereas if they're in color, it will indicates more a standard microscopy, but the same rules apply. You can see they look very similar. It's just the color difference. So we have a cast here. It's got parallel sides. It looks kind of cigar shaped. It's got a rounded edge. In hyaline casts, it contains no cells. So there's some little blobs here and there, but that's nothing important. They're effectively empty shells, so to speak, just containing a gelatinous mucoprotein, which is the Tam-Horsfall matrix you might remember from pathophysiology days. We'll try and avoid thinking back to those days. And less than one hyaline cast per low power field is normal, but if we're seeing any increased number of those, it would indicate we've got a problem. And with hyaline casts, we tend to find increased numbers in animals with either glomerular proteinuria or pre-renal proteinuria. Compare that with granular casts, which you can see on your screen here. They're effectively hyaline casts that contain some granules, so they kind of look a little bit similar, but with granules inside. So they're no longer transparent. They can have either a fine to coarse textured appearance, and once again, very low numbers are considered normal, but increased numbers should cause concern. But we should be interpreting the presence of casts alongside other parameters such as your blood biochemistry, and if there's an azotemia, etc., and other evidence of renal problems, then they're of higher significance. But an occasional cast without azotemia should not raise too much concern, as it could be transient. But we can see increased numbers of granular casts with tubulointerstitial disorders, pyelonephritis, or acute renal injury. So if you're seeing these in any number, it's an indication that we need to dig a little bit deeper to find out why the kidney isn't happy and why it's shedding these casts into the urine. So now we'll move on to crystals. I'm sure most of you will be very familiar looking at crystals, but a little refresher doesn't go amiss. Probably the most important take-home message from today is that crystalluria does not equal pathological, and I think crystalluria is often over-interpreted in veterinary medicine. We can identify crystals in completely healthy animals, and not every animal with crystalluria needs an intervention. So their presence definitely does not equal significance. We need to look at the big picture. We need to look at the age of the sample. We need to look at the reason the cat has presented to us in the first place. Same rules apply to dogs, but obviously today we're focused on the cat. So what is responsible for crystal formation? Well, it's dependent on a whole variety of different factors. So urine pH will depend on whether certain crystals dissolve or precipitate. Urine-specific gravity plays a role. The temperature of the urine plays a role. The animal's diet, the time from collection to analysis, which should be as short as possible. I've harped on about that so often so far today. And also whether there's any bacterial contaminants. But remember that the presence of crystals does not necessarily mean that the patient has uroliths, nor the predisposition to urolith formation. We can see crystals in totally healthy animals. Equally so, animals that do have uroliths, the crystals don't necessarily predict what type of urolith that is. That would be too simple. Life would be too easy if that was the case. So the presence of crystals doesn't necessarily always equate to telling you what type of urolith that particular patient has. So when are they significant? Well, there's a number of circumstances where I'm more likely to be concerned about the presence of crystals. The first one is if they're identified in very fresh room temperature urine. So if you've sent your sample to the lab and it's more than 24 hours old by the time the sample is analysed, or worse than that if it's been sent over the weekend, and it says that there's either struvite or calcium oxalate crystals present, that may not be representative. They may have precipitated in transit. So it is really important, even if you're sending your sample to lab, that you have a quick look down the microscope before you do that to see if you can identify these elements such as crystals or casts, which might change over time en route to the lab. Do remember that we should only be looking for crystals on room temperature urine. We can also have increased significance of the presence of crystals when the urine is dilute, when there's a concurrent hematuria, or when that crystalluria is present on repeated samples. So if this is the second or third time that the same animal has shown to have crystals, then clearly that's more significant than a one-off. And clearly the most important factor to take into consideration is whether there are any clinical signs that might be related to crystalluria. So that's going to include your signs of FLUTD, such as stranuria or dysuria. So, to chill or not to chill, that is the question. I've mentioned that the temperature of urine can change our interpretation. So just to give you a little overview of what to expect and why it's important to make sure the temperature of the urine is taken into account when performing urinalysis. So if you perform analysis on chilled urine, there's an increased chance of crystals forming. So there's a risk of false positive for crystals. We also know that chilled urine has changes the pH, not the pH, sorry, the specific gravity to some extent. So all forms of the urinalysis should be performed on room temperature urine. But in room temperature urine, if it's left at room temperature for too long before analysis, we know that can also result in changes. So we can get an increase in pH of the urine due to the escape of carbon dioxide from the sample, and also potentially due to bacterial overgrowth. So I'm not saying leave the urine sample at room temperature all the time. I'm just saying that if you're going to perform the analysis, bring that sample back to room temperature before you do it. If you can't do the analysis straight away after that sample is collected. So the types of crystals, I'm sure you'll be very familiar with, but just a quick overview nonetheless. The most common ones we're likely to see in cats include struvite, triple phosphate, whatever you want to call them. These can be present in neutral to alkaline urine. They tend to be colorless and 3 to 6 sides. Some people describe them as looking like coffin lids. Other people describe them as looking like rooftops. I guess both are very similar. But don't forget that they may be seen in healthy animals. So presence of these does not equate to needing to make immediate changes to the animal's management. We have to take it in context with the bigger picture, the animal's clinical signs, the age of the urine sample, and all those kind of factors. We can also see crystals in patients with bacterial UTIs, but that does tend to be more associated with dogs than cats. But we'll come on to the differences of that later on. But I'm sure you're very, very familiar with how struvite looks on your microscopy. But the presence of struvite does not immediately mean the need to intervene. The same is true for some types of calcium oxalate. Calcium oxalate crystals can be found in acid, neutral, or alkaline urine, more typically in acid to neutral in my experience. We will see them at times 40 objective. They tend to be colorless. We can see that 2 forms exist, so I'll go through these on the right-hand side of the slide here. We can see at the bottom, we've got ones that kind of look like envelopes, if you'll give me that, yeah. These are the dihydrate forms. So these can be present in normal animals, both dogs and cats. So seeing these does not necessarily mean need to overreact. These can be present in totally healthy animals, as well as in pathological states. But the other versions that we have are more concerning. So at the top of your screen, you can see either what we call the rubber dinghy version of calcium oxalate or the picket fence version of calcium oxalate. And these are the monohydrate form. And the reason these are so important is that if we see these, then it may be associated with ethylene glycol antifreeze toxicity. So if you have a patient where they're presenting unwell, or the owner has said there's a chance that the animal might have consumed antifreeze, looking for these can give you the heads up that yes, there is definitely a problem. So the monohydrate form isn't something we see very commonly, and when we do see it, something like ethylene glycol intoxication is something that we need to be concerned about. When these do occur, they tend to occur within about 3 to 18 hours after ingestion of ethylene glycol, and that's usually well before the azotemia develops. So that's when you want to be able to confirm what's going on. That's when you want to be able to intervene before the damage has been done. So we're mainly going to be thinking about dihydrate because they're the ones we're more likely to see. And although they can be present in healthy animals, they can also be found in animals with pathological states such as hypercalcemia and other endocrine conditions in dogs, but that doesn't really apply to cats. So hypercalcemia may predispose an animal to calcium oxalate crystalluria. Also just wanted to mention a couple of other type of crystal that you might be less familiar with. We have ammonium urate. On standard microscopy, they tend to be a kind of brown yellow color. On SEDI view, obviously everything is black and white or gray. They tend to be called thorn apple appearance, so kind of round with these kind of spiky bits on them. I always think they look like squashed mites on the microscopy. They tend to be found in either neutral to acidic pH, and we don't tend to find these in normal animals. So if you identify these, it does generally mean there's a bit of a problem. And the most common condition we think of when we see an animal with lots of urate crystals is a portal vascular anomaly, so a shunt, if you like. But it can also be a genetic disorder. So if any of you are seeing fancy breeds like the Egyptian Mau or the Siamese, these breeds may have a genetic disorder which predisposes them towards producing these types of crystals. So in anything other than these breeds, possibly in these breeds as well, it may be an indication that the presence of urate means that you want to be doing a bile acid stimulation test to assess liver function, and also just checking that the animal isn't on a really high purine diet, which otherwise could predispose towards this. So lastly, as far as crystals are concerned, I wanted to mention bilirubin crystals. These on standard microscopy tend to be golden brown to yellow, on SediVue black and white, as I've mentioned. So they kind of look like needles or wheat sheaths, if you like. In dogs, which we're not talking about today, but just a word to the wise, these crystals can be normal in dogs with very concentrated urine. We can get up to 2+ bilirubinuria in a normal dog with concentrated urine and subsequent bilirubin crystals, but they are always abnormal in the cat. So if you're seeing bilirubinuria in the cat, if you're seeing bilirubin crystals in the cat, that's always an abnormality, and it means we have to go looking for underlying reasons for cholestasis. So let's move on to bacteria in the urine and how we can identify that and how we can be confident of our diagnosis. So when we look at a urine sample for bacteria, if we're going to identify bacteria, we tend to find that rods are more common than cocci. Once again, we need to try and look for bacteria in fresh urine samples, because bacterial populations can double every 20 minutes, but the bacteria can also die en route to the laboratory due to phagocytosis by the white cells. So once again, it's really worthwhile you having a look in your microscope before sending the sample to the laboratory to see if you can identify any bacteria. It is easy to misinterpret bacteria because they're effectively, well, let's face it, just little small blobs. So sometimes it can be very difficult to be certain of what you're looking at. But you can see here, hopefully, in the SediVue image at the top, that we've got some cells on the left-hand side, which are the white cells, and we've got these little rods, which are in the urine samples. So they're relatively obvious. I would like to say it's always that obvious, but that's just not the case. Compare that to the bottom image where it's quite clear it's almost like a necklace chain. So these are chains of cocci bacteria. And here, once again, on the image to the right-hand side of your screen, you can see that the rods are being identified, and we've got some white cells in the background. So some bacteria in a voided sample would be considered totally acceptable because there's the urogenital tract, the external genitalia is not a sterile environment. So some bacteria in a voided sample is not cause for concern. But what we want to take into account is the animal's presenting signs, the method the sample has been collected, and the number of bacteria that are present if it's being sent to the lab. Just to mention here, if those of you who are using a SediVue sometimes come across the analyzer telling you that there's bacteria suspect presence, that means that it's not totally certain what's going on. And in that case, what it wants you to do is confirm the presence or absence of bacteria by other methods. Now, you should all, even if it's just stored in your cupboard somewhere, have a bacterial confirmation kit which comes with the SediVue. And effectively what this does is it dissolves background debris, and we then rerun the sample, and it will allow us to determine whether, after dissolving that background debris, whether those are truly bacteria or not. So if you do have a SediVue and it comes up suspect presence, I strongly advise you to then use the bacterial confirmation kit to be more comfortable with whether it is a real finding or not. But of course, the other option is an image review. And I guess potentially the gold standard is to look at a dry preparation or culture. Gold standards may be a bit strong, but a way of confirming that the bacteria are present is by looking at a stained preparation or by performing culture. But very small particles of debris can resemble bacteria, and Brownian motion isn't really reliable in confirming the presence of bacteria because all small particles have that. So it can be difficult to be really confident in the presence of bacteria in some cases. So how do we perform a urine dry prep? And I think this is something that's very rarely done in practice, which is sad because it's actually fairly easy to do and something you're used to doing for blood smears, etc. So it's very similar to that. So same rules apply as for a wet prep. We want to centrifuge the urine for 5 minutes at low speeds. We want to then resuspend the sediment and place 1 drop on a glass slide, just as you would have done for a wet prep. But this time, rather than placing a cover slip over that and looking on the microscope, we're going to spread that drop as if you were making a blood smear. But rather than with a blood smear, which is a nice smooth motion, not lifting the spreader slide, instead what we're going to do is stop abruptly in the middle of the slide, giving us a nice fine line of cells right down the center. We're then going to air dry that and stain it, and it's very, very good at concentrating all the cells in that region and allowing you to look for both bacteria and cells. It's not any use for crystals or casts. You have to do your wet prep for that. But if you're worried about the presence of bacteria and you're not too sure, this can be a nice way of producing a high quality slide that you can stain and be more sure of your diagnosis. So that's a run through of what urinalysis can do and how we can utilize that in the investigation of urinary tract disease. But let's go back to our case study about a little moo cat. What happened to her? So I performed her urinalysis, and remember that there was the tensions between her and the other cats, and I was totally convinced that this was going to be an FIC. So I was a little bit remiss in acting too quickly, other than trying to have a memo and changing the environment for the cats to try and reduce stress. But we discovered that when we did her urinalysis, she had a pH of 8.5, so more alkaline than usual. Our urine specific gravity was quite dilute, but we knew she had kidney failure, so that wasn't a great surprise. There was lots of blood. We could see that from the physical examination, but there were also lots of white cells and some epithelial cells. But there were bacteria absolutely everywhere, and we could see that there was rods on the in-house cytology, and we then submitted that to the lab for culture, and it had a high concentration of E. coli. So even though the most common reason for signs of FLUTD in the cat is feline interstitial cystitis, there are occasions when these animals will throw you a curveball, and urinalysis can really help to try and differentiate between the potential underlying causes. So I just want to finish off by giving you a little bit of an overview about bacterial UTIs in cats, because bacterial UTIs in cats are actually pretty rare. So only 1 to 2% of cats will have a bacterial UTI in their lifetime, but they are more common in older cats. But if you have a cat a sign of an FLUTD, so stranuria, dysuria, whatever, up to about 20% of those might have a bacterial UTI. So they do exist, but they're not common. When they do occur, they're going to occur most commonly in older cats and older female cats. And they're much more common in cats with both kidney disease or hyperthyroidism or both. So you can see here that my cat had all the classical criteria. She was an older cat, she was female, she had chronic kidney disease, and she was hyperthyroid. So I should have been sharper and quicker to realize that it wasn't going to be an FIC and that actually there was likely to be an underlying bacterial cause. When a patient has a bacterial UTI, a cat has a bacterial UTI, predisposing comorbidity will be present in more than 75% of cases. And this is a very nice paper, which I would direct you to if you're interested in more information on that. Oops. Try and get it to move forward. So I also just wanted to take the opportunity to remind you about responsible antimicrobial usage in FLUTD. I certainly know in the practice where I work, some people are a little bit quick to reach for antibiotics. And as I've just explained, for FLUTD cases, which are the symptoms of urinary tract disease, it's actually quite uncommon that it will be a bacterial UTI unless there's comorbidities, unless it's an older female cat, as I've just explained. So these are rare. So when you have a cat presenting to you with signs of FLUTD, reaching for antibiotics empirically is really not the right way to go. It's rarely indicated in cats because of the low risk of it being a bacterial UTI unless there are comorbidities present. If you're faced with a cat with what's called sporadic cystitis, which is just a single episode of cystitis, and it is likely to be due to a UTI and a bacterial UTI, then it's indicated that you wait until the culture and sensitivity come through before deciding to treat, unless there's a high risk of pyelonephritis. And when you do treat, it's only a 3 to 5 day course. A very short course should be more than sufficient, and that choice of antibiotics should be based on the culture and sensitivity. If you then have an animal with a recurrent cystitis, which means more than 2 episodes within 6 months of each other, you can use the same antibiotic again for another 3 to 5 day course. Ideally, once again, you would culture to be certain, because these will generally be different organisms. So knowing that it's going to be an acceptable antibiotic choice is very important. Or if it's a persistent infection, a longer course of 7 to 14 days. But generally, a 3 to 5 day course for a confirmed bacterial UTI is more than enough. If there's a high risk of pyelonephritis or confirmation of pyelonephritis, then the current guidelines are to treat for between 10 to 14 days, and that should be based on culture. And if you do have any cats in with FLUTD and you've catheterized those because of any form of obstruction, it's not warranted to give prophylactic antibiotics. So there's a very nice review from ISCAID on the use of antimicrobials in these patients, but another take-home message is bacterial UTIs in cats are rare, and empirical treatment really isn't indicated. If you do treat, it should be based on culture and sensitivity and based on firm evidence of the presence of bacteria in the urine. So in summary, I hope from this presentation you'll agree that urinalysis is an integral part of the investigation of the FLUTD patient. Also, I hope you take home that where possible, urinalysis should be a patient-side test because of the risk of changes over time, which might affect your interpretation of the clinical picture. And even though sediment examination can be somewhat time-consuming, it really is a vital part of urinalysis to look for crystals, casts, epithelial cells, and also potentially things like bacteria. And most importantly, when it comes to urine, fresh is most definitely best. Thank you very much for your attention.